Intermittent fasting is actually not good for our hormonal system. It does tend to shut down and suppress the hypothalamus, even if you are overall eating enough.
Yep, more of this to come, but let's get started with the beginning of the interview.
Hi there.
Hi, Nicola. I'm Carly. It's so nice to finally meet you. I
Nice
have
to meet you
almost read
too.
your book cover to cover, and I just cannot thank you enough for all the time and energy that must have taken. That truly is the Bible for HA.
Thank you.
And not only that, but the personal responses, like they really hit your soul. Like,
Mhm.
okay, I need to do this.
Uh-huh. Uh-huh.
So I'm probably one of your typical patients or your clients. Somebody
Yep.
who is practicing all the seemingly healthful things and getting themselves into trouble because of taking them to an extreme. And
Yep.
maybe taking things a little too literal for populations who probably they don't fit into. So a lot of the recommendations out there these days are for people who are obese or hypertensive or diabetes, and men. So many of the studies are on
Yep.
men that when
Yeah.
it comes to women, they're like, I'm really not sure how to deal with you.
Yep.
So yes, I went through all of the misdiagnoses and well, maybe it could be this, possibly, but I'm not an athlete and I'm not
Mhm.
super scrawny. So it was like it was a big mystery for a lot. I saw 6 doctors before I got the final diagnosis.
Wow.
So when it comes to my viewers, many of the I'm a basically a weight loss and nutrition coach. So I help a
Okay.
lot of people lose weight.
Uh-huh.
So I want to make sure I'm not sending the wrong messaging. And I want to make sure that people are cautious when practicing some of the things that I've recommended on my channel, because clearly there's a place for some of these things. And then there's a place where you can take them a little too far, like in my case. So I'm just going to go ahead and get started unless you had any questions. Or
Nope. Nope.
I really haven't discussed this problem much with my background to my viewers because I'm not sure how to interpret it yet. I'm not sure how to communicate what
Yeah.
I've learned and what's going on in my body. And you know how the emotional roller coaster is when you're gaining weight and you're like not exercising and you're like, oh my God, I have to get in front of a camera. Okay,
Yep.
so the problem is basically that I have been recently diagnosed with hypothalamic amenorrhea, or HA, which we will likely be referring to it from here on.
Yep.
After 5 years of following what the research has shown to be optimal behaviors for long-term health and longevity. So things such as consuming a low-calorie diet pattern, intense exercising, following a time-restricted eating or intermittent fasting schedule, minimal daily caloric restriction, intense heat and cold exposure. I was
Mm-hmm.
practicing all these extreme behaviors in the name of health.
Mm-hmm.
Chronically, these habits have resulted in the opposite effect. So to help me and my viewers gain a better understanding of this seemingly backwards phenomenon, I have invited one of the leading experts on HA to my channel today to sort out some of these myths and misconceptions around leanness, weight loss, and hormonal health. So welcome, Dr. Nicola Sykes has a PhD in computational biology from MIT. Congratulations.
Thank you.
After graduating, she pursued her dreams of starting a family, which she was thwarted by a diagnosis of hypothalamic amenorrhea, or having a lack of natural periods. She spent the next 18 months trying to conceive and immersed herself in research to learn how to recover from HA, or hypothalamic amenorrhea. Ultimately, she was able to achieve a natural pregnancy from what she had learned about the natural recovery process. And since that time, Dr. Sykes has shared her knowledge of the path to recovery, helping hundreds of others regain their cycles and achieve pregnancy. I am so excited to have you on my channel today. Thank you so much.
Thank you so much for inviting me. I really appreciate it.
So let's just start with the basics. What the heck is HA and how do people get it?
So HA, hypothalamic amenorrhea, kind of, it's all in the name. So in your brain, there's this little part called the hypothalamus, and it's kind of one of the major control centers. So it takes in input from all over your body. It takes in hormonal input. It takes in physical inputs. It basically synthesizes them and then sends out signals to a bunch of your other hormonal systems. So it sends signals to your pituitary, to your adrenals, to your ovaries, to your thyroid. So all of those are actually controlled by the hypothalamus. So it's sort of the body's master regulator, and it controls our reproductive system through the pituitary and the ovaries. So the amenorrhea part is missing a period, missing a monthly period. The technical definition is no period for three or more months. That's the sort of the definition of amenorrhea. And so it's basically amenorrhea because your hypothalamus is shut down or suppressed. So it's sort of part of what's now called relative energy deficiency in sport. So that is sort of a larger cluster of symptoms that all are associated with basically underfueling. Typically, I mean, relative energy deficiency in sport, typically they're talking about underfueling, exercise. It can happen to somebody who's not doing a lot of significant exercise, but just underfueling for their body's needs. And the reason is that the underfueling basically sends signals to our hypothalamus, or lack of signals to the hypothalamus. And so the hypothalamus isn't sending signals on to then the pituitary and the ovaries. So when I wrote No Period, Now What, it was right around the time that the relative energy deficiency in sport cluster was defined. Before that, it had been called female athlete triad. So that was really focusing on sort of the amenorrhea, so the underfueling, amenorrhea, and bone density consequences of being amenorrheic and underfueling. The relative energy deficiency in sport sort of incorporates effects on a lot more systems. And I mentioned a lot of these in my book without having sort of known that it was called relative energy deficiency in sport at the time. So there's a lot of other things that are associated with sort of the effects of the underfueling and not having a period. Things like feeling cold all the time, not being able to sleep because you have to urinate a lot at night, waking up hungry in the morning, having a lot of GI issues, no libido, no lubrication. There's also some mental aspects of feeling anxious, sort of the hangry type phenotype. So, there's some immune effects. There can be effects on bones. There can be effects on hearts. So there's actually a lot of negative consequences of underfueling for our body's needs. And it's just hard because in our society, we are so focused on don't be too big, all the health consequences that are seemingly associated with being in a larger body. And so we're consistently encouraged from a very young age to underfuel, to exercise as much as we possibly can. It just sort of creates this disordered relationship with food and our bodies. There's so much like body image stuff, like you have to look a certain way in order to be considered desirable, in order to get the better jobs. I mean, there's so much in our society that is focused on sort of the underfueling and the sort of resultant physical appearance. So that's a long answer to a short question.
No, that's perfect because you answered many other questions that I had.
Great.
Give people a little perspective. Like some of the things that led me to seek out help for this problem were the extreme fatigue. And I was actually having problems. I was working with a PT for pelvic floor problems after having my child. I assume I got HA either from doing some of these behaviors while I was pregnant. So I was trying to, like you did, I was trying to maintain a low body weight for my pregnancy because that's what the doctor said was healthy. So after a while, it got to a point where I was so cold all the time and I was so fatigued. But why I was working with the PT for the pelvic floor problems was the urinary incontinence and the frequency and the urgency. I'm like, I'm 35, this isn't happening. So following that, I also had a diastasis recti.
Yep.
So I was so bloated and constipated that my PT was like, you're never going to heal this thing if you don't get this dysbiosis under control. So I was working with a GI to figure that out and a urologist to figure out that and the pelvic floor person to figure out that. And it was just like, can't you guys just figure out this is all the same problem?
Yeah. Yes.
So this is just like any of those diagnoses or those lack of diagnoses where you're going from doctor to doctor to doctor and specialist to specialist, and you're trying to figure out what's wrong with the whole, what's the underlying, and thankfully it's one thing causing all these problems. Not so many people are that lucky, but just to give some people some background for, some seemingly
Yeah.
unrelated things
Yeah.
that you wouldn't naturally put two and two together with not having a period. And they
Yes.
also told me that since I had just quit breastfeeding a year and a half ago, 2 years ago, they're like, oh, it'll come back any day. Don't worry. That's totally
Hmm.
normal. I was like,
Hmm. Hmm.
okay.
Yeah, I mean that's one thing that I really dislike about some of the advice that's given on a missing period is, oh, just wait and it'll come back. It's like, I mean, there is a small percentage of people for whom that's true. They wait a month or two, say after going off the pill or, after breastfeeding, and their periods do come back. But, I mean, that's why the first three chapters of the book are sort of a listing of like the different ways that our behaviors can be sort of detrimental to our body's ability to resume cycles.
Mhm.
So I mean, it's common for doctors to say, oh, wait 3 to 6 months after coming off the pill, before you even worry about anything. But the studies actually show that when they looked at a large number of people sort of coming off the pill, I think 90% had ovulated by 1 month after coming off the pill, and the other, 95% by 6 weeks. So if it's 6 weeks after and you don't have a period, there's probably something else going on. It could, I mean, there's a lot of things that it could be. It's not necessarily HA, it could be polycystic ovarian syndrome, PCOS. It could be a thyroid issue. It could be, it's unlikely if you've had a period when you're on the pill that it would be some kind of physical issue preventing you from bleeding. But that is a possibility. There can be a pituitary microadenoma, which can increase your prolactin, and that can prevent you from cycling. So all sorts of things that could be happening. And so I think it's worth investigating. Like if it's been 6 weeks and you haven't ovulated yet, then it's time to make an appointment with your doctor and, not just just wait a bit longer for an answer. Like, they should be doing blood work. They should be doing an ultrasound. I mean, blood work is a good place to start because that can give you a good idea of, is your TSH normal, your thyroid stimulating hormone? Is your luteinizing hormone normal? That's LH. And I find that LH is actually the best marker of hypothalamic function. So in controlling the reproductive system, the hypothalamus secretes a hormone called gonadotropin releasing hormone, and it secretes it in pulses, like every 3 to 4 hours. I've seen every 3 to 4 hours. I've seen every like 90 to 120 minutes. So anyway, it secretes in pulses, but it's at a very low level and it degrades really quickly. So it's not something that we can measure in the blood. But every time the hypothalamus secretes that gonadotropin releasing hormone, that then goes to the pituitary, and the pituitary secretes luteinizing hormone in sort of the same pulsatile fashion. And luteinizing hormone stays around for longer, so we can measure that. So people with HA often have low levels of luteinizing hormone. And so that's a good marker for, okay, this is likely something of hypothalamic origin. Another thing that I forgot to mention as a possible cause for missing periods is primary ovarian insufficiency or premature ovarian insufficiency, which is basically early menopause. So that's something that can happen to people. So in that case, your FSH and LH would be really high. So blood work is a really great place to start. So I think really important for people not to take, oh, just wait a few months as an answer. Like that is not a medically appropriate answer. It's not supported by evidence. So, I think if your doctor is completely unwilling to do anything, go find another doctor who will.
Yes, and in my case, it was 6. And
Yeah.
in the end, I was still the one to put all the pieces together, so just do your research, please.
Yeah.
You brought up so many good points. I I find it very difficult for so many women who don't have the period, and they're like, "Fantastic, this is awesome. I don't have to worry about tampons and whatnot." And people who are on the pill and they're bleeding and they're thinking that that's healthy or that they don't have to worry about the potential for amenorrhea. You can still have amenorrhea even if you're bleeding on the pill. That blew my mind. Unless you're at a
Yeah.
very severe point in your illness, then
Yeah.
it stops. But
Yeah.
yes, so some interesting things. And I was also curious about people who are menopausal and they're in an energy deficiency for so long. Like, they can't have HA, but do they get something
No,
similar?
I mean, it's, I think I have worked with a few people who are postmenopause and they just, they have the same cluster of symptoms. It's just you don't have the period to sort of
Okay.
be a marker for that, sort of general body dysfunction. Same thing in people with testes or, whatever. Like there isn't that period to sort of indicate that there are problems, but, everybody can experience these negative symptoms from the consistent underfueling. So it is things like feeling tired all the time, feeling anxious. I mean, that's not the best, but I think feeling tired all the time, the GI distress, feeling cold a lot, that's a really good marker. And so then assessing your habits, like, are you intermittent fasting? Intermittent fasting is actually not good for our hormonal system. It does tend to shut down and suppress the hypothalamus, even if you are overall eating enough. If you're sort of getting up and going about your day, your hypothalamus is sensing an energy deficiency, even if you're eating more later in the day. And particularly for those of us that have more sensitive hormonal systems, that can be enough to shut down our period. It can also cause all those other negative symptoms. um
Right.
so
And there is that genetic component that is so
yes.
important too.
Yes. I mean, definitely some people are more resilient to starvation than others. So it's like you can't compare yourself to the person next to you because you have different genetics from them. And it's most obvious with periods, because that's a sort of defined marker. Like, are you getting a period or are you not getting a period? And really, it's ovulation that drives that, everything that we talk about with a period. Like, ovulation is the important event in the cycle. The actual bleeding, doesn't really matter. So it's the hormonal changes that happen to cause ovulation, and then after ovulation, that's what our bodies really need. So the increase in estrogen before ovulation, and then after you ovulate, both your estrogen and progesterone go up to much higher levels than sort of when you're at baseline. And that time during your cycle, the luteal phase, is really when that's the time when your body is sort of most building bone, and it's most supportive of your heart function. So there are actually studies that find that women are more likely to have a heart attack during the first half of their cycle, like during the follicular phase when your estrogen and progesterone are on the lower side, and less likely during the luteal phase. Fascinating.
Yeah, super fascinating.
It's so interesting.
So the lack of elasticity in the arteries and such, and the lack of nitric oxide production,
Yep.
I think you
Yes.
mentioned, and
Yep.
for like the heart complications that they think have something to do with the higher incidence in heart attack for postmenopausal women, and for
Yep.
women who have had their ovaries and such taken out prematurely for medical
Yes.
reasons. So not
Exactly.
only the heart complications, you mentioned the osteoporosis, osteopenia that can come from this, which thankfully we think at the moment these are all reversible.
Yeah, I mean,
Hopefully.
it definitely seems that the heart issues are reversible. I've certainly worked with a number of people who have had lower bone density that have gotten their cycles back and had nice increases in bone density. Although I did just have somebody the other day who said that she's had regular cycles and hasn't really seen an increase in bone density. So it's not true for everybody, but certainly the most of the people that I've worked with that have had serial bone scans after getting their periods back have found that there has been an increase in bone density.
Mhm.
Obviously, ideally, we don't ever get into the situation in the first place, and then it's less worrisome. I mean, there's certainly other things that can cause lower bone density. This is not the one and only. Um, but
Yes.
particularly for teenagers and people in their early 20s, like, that is the time when your body is building the most bone. And so I think really important to stress the importance of fueling your body well and ovulating during that time. Being on the pill it is a substitute in some ways, but the studies that I've seen seem to suggest that, unless you're on the type of pill where you're sort of on it consistently for like almost 3 months, the pills where you bleed every month, it sort of maintains your bone density where it is, but you're not increasing bone density as you should be, particularly in your teens and 20s. There does seem to be some evidence that the longer use pill is better for bone density. So, I think I would certainly recommend that if somebody wants to be on the pill, for contraceptive purposes or what have you. Um, I'm
Mhm.
just about to put out a separate chapter on contraception. I just need to have a few more people look over it. But I do think that, if one is going to be on hormonal contraception, that the hormonal IUD is actually probably one of the better choices, because it does still allow for ovulation. You just don't your bleeding is significantly decreased, and then obviously it's a very good choice, contraceptive wise. Um, So sorry, tangent.
Oh, that's great because I actually have had the copper IUD, the non-hormonal
Hmm.
IUD, since
Hmm.
I had my child almost 5 years ago, and they
Yeah.
told me that there was a small chance that that was blocking my flow. I'm like,
I
so
mean,
like,
maybe blocking your flow, but it certainly wouldn't be preventing you from ovulating.
yeah, or
Um,
having all these other slew of problems because all of
yeah,
my
yeah,
hormones are have plummeted like
yeah.
drastically.
That's
Like,
not
yeah,
because
you
of the
had this.
IUD. Definitely not.
Yeah. So some other things that I found were detrimental for the long term were liver complications and brain and cognitive
Hmm.
decline. So obviously, if we're in a starvation mode, we're not getting enough fuel for our brain. That can cause like some shrinkage and aging of the brain. But also, I found it was so fascinating that in a weight loss, everybody thinks they're just losing fat, right?
Hmm.
They don't think
Hmm.
about, yes, they're losing some muscle, some protein, but also you are losing a percentage of your organ tissue and your bones. I
Yeah.
was like, hold on. Nobody talks about that.
No, they
Like,
really don't.
no
They
wonder
really
my
don't.
body is like trying to, compensate for all of the lack thereof. And, anyway, so yeah, this has been
Yeah.
quite a journey. So I'm
Yeah.
really thankful to
And
have you here.
some of that is more conjecture than evidence, honestly. I mean, in terms of losing organ weight, like that's a hard thing to study. So, like I found an article about weight loss in mice, and if a mouse lost 10% of its body weight, then it lost 20% of its kidney weight and 30% of its liver weight, or vice versa. I can never remember which is which in terms of the percentage with kidney and liver. But as you were saying, like the assumption that is pushed upon us by the culture that we live in is you lose weight, you're losing fat, and that's a good thing. And no mention that actually fat is a hormonal organ, and it converts testosterone to estradiol. So when somebody has HA and they have a low baseline estradiol level, that's usually associated with low body fat, because our adipose cells are part of our hormonal system. They also secrete leptin, which is measured by our hypothalamus. So that's one way that the hypothalamus sort of knows, are you in the set range that your body wants to be in, is sort of that leptin. There are a few other hormones as well. That interaction with or the messaging that's sent out by your adipose cells. So it's definitely way more complicated than sort of diet culture makes it out to be, in terms of lose weight and you're losing fat, yay, good for you. But like, yeah, I mean, certainly, there do seem to be some complications of, being in a larger body, but I think a lot of, there's also a lot of complications of sort of the yo-yo dieting, and so many of the diets that are recommended are just unsustainable for the long term. And so, you lose a bunch of weight really quickly and it's like, woohoo, look at me. And then you can't sustain those habits over time. And so you end up getting back to even a higher weight. And so there is evidence that sort of this yo-yo dieting is actually more detrimental than being in a larger body and just kind of being a larger body. And, we're not all meant to be the same size. We're not all meant to be model thin. And, there's just so much, like all the photoshopping and all of that. I mean, oh my God, really, like it's never ending. It's just so many little rabbit holes we can go down.
I
So
know, I know. That's why this conversation is so hard. I want to touch on
yeah,
everything, but I'm
yeah,
trying to
yeah.
stay structured so the viewers aren't like, what happened? Okay, so I would love to touch on the yo-yo cycling in a moment.
Mhm.
But can I ask real quick, just some general questions around nutrition? Because I know that you typically recommend in this wonderful book that I definitely suggest everybody read if they are interested in the topic or feel that they are, having any sort of these symptoms or are having problems getting pregnant. Because I find that more times than not, this may be the case, not just for women, but
Mhm.
for men. Like if you're
Yeah.
waking up without erections, or if you suddenly are a woman and you no longer have lubrication, or you're getting a lot of like dryness and stiffness vaginally, or if you're no longer having a libido, these are all great, red flags to go
Yeah.
get something checked out about this.
Yeah.
And
Yeah.
this could
And that's
potentially
that's a really good that's a really good point about the morning erections. So it's the male hormonal system is actually not that different from the female hormonal system. So, There's also the hypothalamus sending out GnRH in a pulsatile manner that goes to the pituitary that secretes LH and FSH, and those actually help with with sperm production and testosterone production. So it's actually fascinating because it's one place where the hormones were named based on their function in a female body, but they're it's a universal system. So I think that, again, like, it's easier as a person with a uterus to know, okay, I'm not getting my period, I have a problem. But the morning erection is actually a really good sign for people with testes that that there's something going on, particularly if that's something that's changed and you've gone on a diet, or you increase your exercise intensity and maybe you haven't increased your food intake to go along with that increased exercise. That's a really good warning sign that you need to
Yes.
take a look at your habits and see if you're fueling yourself appropriately.
Yeah, absolutely. And that's what we'll be talking about. So in your book, you recommend about 2,500 calories moving forward with somebody with HA in recovery mode. So I'm just curious. I know you've mentioned in past interviews and in your book that the demarcation line for the current recommendations on
Mhm.
like 1,200 up to 1,800 calories for weight loss, and then the general 2,000 calories for women, 2,200 calories for men per day. How were those determined, and what are your general inclinations towards where they should actually be?
So my understanding is that the sort of 2,000 calorie a day number came from self-reported surveys. And so people reporting, I ate this much in a day and my body weight is stable. And so the assumption is when you're eating, when you're eating to your body's needs, that your body weight is stable. Um, but surveys are notoriously unreliable, and people can judge how much of something they're eating differently. There's just so much variability and unreliability, and it tends to be the case that people underreport what they're eating when they're doing these kinds of surveys, because there is sort of this general idea of like, oh, you shouldn't be eating that much, or you should feel guilty about eating this, and so people might forget a snack, or they might, whatever the reason is. So there are two different methods that have been used, that I think are more accurate than those surveys, to assess how much somebody is actually taking in a day. And then again, the assumption is somebody in a stable body weight is eating to their needs. Although, I mean, you can have a stable body weight that's much too low for you and you're underfueling, and so it's definitely a complicated equation. And I would not take that as, if you're significantly underfueling and you're exercising all the time and you've stopped losing weight, like some of that is just your body protecting itself. Like, some people have commented that they actually start gaining weight, and when your stress hormones are really high, that can impact the way that your body stores energy, and so it can lead to some weight gain even when there is an energy deficit. So it's all really complicated. It's definitely not calories in, calories out. So anyway, the researchers did there are two different methods. One is where you have somebody basically live 24 hours in a room where they're measuring all of the outputs, so the liquids and the gases, and it's called a room calorimeter. And so that in that case, they were actually measuring the energy usage. And so they did it on a bunch of different people, male, female, different sizes, everything. And so they put together an equation, and so that's what I used to calculate, that for sort of somebody of average female size. I mean, obviously, that's actually based on height and not weight, because our lean mass tends to be
Mhm.
more proportional to our height than to our body size. So I say, the 2,500 calories is sort of a rough approximation. If you're really short, it might be a little bit less than that. If you're really tall, it might be a little bit more than that. But that gets really hard to say in a soundbite. So 2,500 is 2,500 is a bit easier. So there's a whole chapter in the book that's devoted to this, and if people are interested, they can read a little bit more about the research and the science. The other method was called doubly labeled water. So there's water that is actually made with, I think, radio labeled hydrogen and, well, it has to be hydrogen and oxygen, right? If it's water, those are the only two, those are the only two molecules in there. It again allows for the researchers to measure the actual energy output for a person for a day. And interestingly, those two methods come up with very similar equations for based on body mass and activity and all of that, how much a person should be consuming in a day. But I usually my recommendation to people is like, think about, what a day would look like for you if you were eating 2,500, because a lot of people are eating so much less than that. I mean, I don't even want to tell you what I was eating when I was dieting. It was really ridiculous. So I really just have those as guidelines so that people have an idea of like what they actually need to do. But I don't like the idea of counting calories every day. I think that adds a level of stress, and it adds some restriction that I think is unnecessary. So I generally tell people, like, count for a day or two, like figure out what 2,500 calories looks like for you. And then just kind of keep eating in that general way. Like, it's okay to listen to your body's signals to some degree. Sometimes when somebody's been underfueling for a long time, they can't listen to their signals for a while because the signals just get shut down and disordered because you've just been, you have been underfueling. Your body's trying to save energy in as many ways as it can. And so it stops actually sending the hormonal signals to indicate hunger, because making those hormones takes energy. And it's like, if I know I'm not going to get fuel in exchange for this energy expenditure, I'm not going to do that anymore. Like, that's a waste. So I think it often has to be a little bit more mindful at the beginning. Like, I know I need to eat this much, and so I'm going to eat, every 2 to 3 hours through the day. And this is going to be the general size of my snacks or my meals or whatever. I'd always tell people, like, if you're hungry for more, eat more, because I think particularly when somebody's starting on recovery, their body's been underfueled for a long time. And so it actually needs more just to get to like a sort of comfortable baseline. And if you're saying like, no, I can only have 2,500 calories a day, well, then you're still restricting. And it does seem to end up taking longer for recovery. Sort of 2,500 is a minimum. And if you're hungry for more, eat more. And yeah.
Yeah, I'm definitely not a big calorie counter, but I found it was helpful just having that parameter.
Mm-hmm.
So, I mean, I've definitely been eating at least 3,000-4,000 calories a day in my first 5 weeks of recovery.
Mm-hmm.
But my appetite is, it's slowly coming back to normal, and
Yep.
there aren't like major body fluctuations. So it's just trying to get back in touch with your hunger and fullness cues and get rid of all of the rules around food. I think that is so important. So moving forward, and from what you've found in your research and from working with women with this condition, do you feel like 2,500 calories is more or less normal for like the average person?
I think it is. I mean, it's hard to say. I think that our needs really fluctuate from day to day based on all of the different things that we're doing. And just life stuff, and like how much you're exercising and all of that. So I think that once you get to a place where your body is stable and well fueled, generally you can just listen to your hunger and fullness cues. And for somebody that might be 3,000 calories a day that their body needs, for somebody else it might be 2,000. Like, I think it's I generally say you should keep eating like this for forever, like fueling yourself really well, and especially fueling your exercise, because I do think that there's a lot of evidence that exercise is incredibly good for us. It's good for our physical body, it's good for our minds. There's very few negative effects of exercise in and of itself. It's the underfueled exercise that's really problematic. I always tell people, like, you can go and do whatever kind of exercise you enjoy and you want to do going forward. Just make sure you're feeling it well. And, knowing also that high intensity exercise does tend to have a little bit of an appetite suppressive signal. So some people, they never sort of intended to underfuel, but they were doing a lot of high intensity exercise and not necessarily feeling as hungry as they should, for their body's caloric needs, which I don't understand. Like, it's one of the pieces of this whole puzzle that makes absolutely no sense to me biologically, but it's, there's a research study that found that this was the case. And I've certainly seen it in a number of people. So just recognizing that when you're doing a lot of high intensity exercise, your body might not be quite asking you for exactly what it needs. And so just being a little bit more mindful to make sure that you're fueling, you're fueling your exercise well, probably fueling during exercise if that's possible, particularly for people who are like endurance runners, having those gels or, I'm not a runner. I don't know. I don't really know those things, but I know that there are ways that you can be, sort of continuing to fuel your body while you're exercising. Obviously shorter intervals, you don't need that. But again, just really being mindful of, am I starting to experience some of these symptoms? I do find that tracking your ovulation is incredibly helpful in sort of understanding how your body is doing with, added exercise or, any changes to your eating. Because often ovulation will get later and later in your cycle and your luteal phase. And so time between ovulation and your period might get shorter. So it still looks like you're having regular periods. They might still be coming every 28 days, but now you're ovulating cycle day 22 and having a 6-day luteal phase. And that's a marker that your body is struggling. And sort of the next step after that is going to anovulatory cycles. And there's certainly research that shows that people who are exercising regularly are much more likely to have anovulatory cycles. So sort of learning your body's signs around ovulation, tracking your temperature, maybe using ovulation predictor sticks. I think all of those are really, really useful tools for monitoring, sort of how your body's feeling about what you're doing.
Yeah, in some of my research and, trying to follow up on this condition, I found that there was rather a high incidence of people, just regular recreational exercisers who have issues with their luteal phase or their LH levels when it comes to high intensity exercise, like running or HIIT is really big right now. So anything that really gets your heart rate up. Would you mind discussing, since we're on the topic at the moment, the study that discussed the no exercise, 40%, 80%, or no, I got that 40, 60, 80% of their heart rate?
Yeah, so I thought that study was really interesting. So it basically looked at cortisol levels generated by different intensities of exercise. So obviously, when you're doing no exercise, your cortisol is at whatever your baseline is. At 40% of max intensity, there was no change in cortisol. At 60% of max intensity, cortisol went up by about 40%, and at 80% of max intensity, cortisol went up by 83%. So cortisol suppresses your hypothalamus. So that's why, particularly when somebody's working on recovery, I say, like, don't, cut down or cut out your high intensity exercise, because that cortisol signal is sending a suppressive signal to your hypothalamus. And when your hypothalamus is already sort of suppressed and, sort of trying to get started again, any additional suppressive signal is basically going to keep it at baseline. So you really need to relieve the suppression in as many ways as possible in order to get it started again. So my general recommendation is keeping your heart rate at about 100 beats per minute or less. And that's sort of about 50% of max intensity-ish. And so, any changes in cortisol at that level would be minimal. And that, that in my experience, that certainly seems to be a place where, most people can get their periods back.
Okay.
So often people will, if they have been a runner, they might start walking instead. Walking is typically fine for recovery, but not if you're walking 3 or 4 hours a day. Like that's more than you need for sort of general health. And so that sort of starts getting into like, well, why are you walking for 3 to 4 hours a day? Like, what is that giving you? Is it, is it obsessive exercise? Is that, do you feel not okay if you're not walking that much? And if so, like that's something to work on. I think that another part of the recovery recommendations is just sort of a lot of us get really dependent on exercise for our mental health. And, it's not awful, but like developing some other coping tools, because you can't always exercise. Maybe you get injured and you can't exercise for some reason. Like I broke my hand last summer and I couldn't do, I couldn't play ice hockey and I couldn't bike for like 3 months. And, but it's like, whatever, I didn't even walk every day. It's like, I know that my body's going to be fine. I mean, I think that that's another thing that's sort of pushed on us by the culture that we live in, is this idea that like, if you stop your exercise, you're immediately going to turn into a puddle of jelly. And it's like, this is not biologically the way that our bodies work. It's just,
It's so
and
true.
I mean, yeah, like don't skip your exercise. But it's like, come on, like, can we be reasonable here, please? Like, again, I think exercise is fantastic. I love playing ice hockey. I love the way that it makes my body feel. I love the camaraderie. I love the stress relief. But sometimes I can't play. And you know what? I'm fine. I'm totally fine. And like, I didn't play for 3 months last summer and I went back and it was like, hadn't really changed. So, this idea that if you take a little bit of time off, you're going to like be starting from ground zero. No, absolutely not. Like, that's just not the way that our bodies work. So,
Yeah.
yeah.
And just to remind my viewers, this is definitely coming from a place of recovery. So
Yes.
when it comes to the average individual, if you want to go above 100 beats per minute, that's totally your prerogative. You just have to keep in mind where your cycles are at, if you're experiencing any of these symptoms and so on and so forth. One of
Yeah.
my problems in acquiring all of these crazy behaviors is that I took everything to heart. I was like, oh, they're
Mhm.
talking to me.
Mhm.
I'm in that population, even though
Yes.
they were directing the information towards people who are obese or diabetic or hypertensive, or discussing intermittent fasting studies that have been focused on male
Mhm.
participants, like
Yep.
having no information on how that would impact the female hormonal cycles. And I'm really grateful for you and your
Yeah.
work to have brought this to our attention. And hopefully this is getting to my viewers in a place that's proactive and preventative.
Yeah.
So
Yeah.
before I want to touch on a couple more things. You mentioned earlier, just so people who are still iffy about the intermittent fasting subject, could you just briefly mention the Swedish athlete study and the 4 hour discrepancy?
Yeah, yeah, absolutely. So I thought this study was fascinating when I came across it. So this was a group, they were looking at a group of elite athletes in Sweden. These women were all eating about 3,500 calories a day and burning about 1,000 in exercise. So net of 2,500 calories a day. Like that's after planned exercise. So, sometimes it's a little bit like mind-boggling to even think about that. And some of them had their periods and some of them didn't. And so the researchers were like, what's going on? Because 2,500 calories net a day should be more than enough for people to have their periods. So they looked at what they called within day energy balance. So it's basically on an hourly basis, figuring out how much they were taking in and how much they were, burning for basal metabolic rate, daily movement, digestion. Nobody ever talks about that, by the way. Like digestion actually takes about 10% of the calories that we eat gets used up just in the process of digesting. Exercise post oxygen consumption. And they found that the women that did not have their periods were in an energy deficit for 4 hours more per day than those who did. So I thought that was absolutely fascinating. And it sort of went along with what I've noticed for a lot of people with HA is they wake up in the morning and they go for their run or they go to the gym and, then you're not that hungry. So you wait a couple hours before you have breakfast. So, maybe you're up for 4 hours before you have breakfast. And in that time, when you think about it, like your body's already used up a lot of its, daily energy overnight because you're still breathing, your heart is pumping, your brain is working, so that is literally your basal metabolic rate when you're sleeping. Like that's the amount of energy that your body is using. And then you go and do all this other movement. And so your sort of immediate energy stores are gone. And so your body has to work a little bit harder to dig into other energy stores. And your hypothalamus senses that. And so it really it's sensing an energy deficit on a daily basis. Even if later on in the day you're eating, the amount of energy that it should need. So I think just that, that sort of period in the morning of completely unfueled movement, exercise, even just daily living can be enough to shut down, to suppress the hypothalamus and shut down the hormonal system.
Yeah. I was practicing intermittent fasting on a rather rigid schedule for
Mhm.
the better of the past 3 years. And I was very consistent with making sure I got my exercise in every morning before I broke my fast. Honestly, it was so uncomfortable for me to eat and exercise anyway. Like
Mhm.
going up while doing my burpees was not something I was interested in. So and then at the end of the night, it was so easy to not eat because then there's all this information about make sure you don't eat this many hours before bed because it
Right,
might interrupt
right.
your sleep and blah, blah, blah. And I have celiac disease, so I have a lot of digestive problems to begin with. So I'm like,
Mhm.
great, I'll fix that
Mhm.
problem. I just don't have to eat at the end of the day. So
Yep.
I thought it was so helpful to see this study, just to see that I was running on fumes, and
Mhm,
that is
mhm.
not always what is, it can be contraindicated for
Yeah,
certain individuals like
yeah,
myself who are predisposed to things like
yeah.
HA.
Did you find that you felt better when you started
Oh,
eating more regularly through
absolutely.
the day? Yeah.
Absolutely. It's like my daughter and I have a whole new relationship too, because mommy's not on edge every morning, and she
Yeah.
doesn't have to walk on eggshells. It's
Yeah. I mean,
wonderful.
it is so true that our mood, and our patience levels can be affected when we're hungry. I definitely find, that's a good sign for me that I need to eat something is when I start snapping at my kids and
Yes,
getting impatient with them. And yeah.
same. Okay, so while we're on the subject of exercise, can we touch a little bit about how HA is related to red S? Because I found it very confusing. Do I have, because my PT told me I have red S, and then
Uh-huh.
the fertility clinic told me I have HA, or no, they actually said hypertropic, hypogonadism, I think it was called. I'm like, Google didn't even know what to tell me.
Yeah,
I'm
yeah,
like, what is that?
yeah.
So yeah, and then overtraining syndrome. So can you kind of like put all these into like a comprehensive bubble?
Yeah, I mean, so it's really, I mean, technically HA is a component of REDS. So it's sort of the amenorrhea piece is your hormonal system being shut down because of the underfueling. So that's one of the cluster of symptoms that happens with REDS. Um, so as I said at the beginning, like I kind of came into this from the amenorrhea side, and then I found this, all these other symptoms that were associated with the underfueling and and the amenorrhea. So it's sort of like REDS is really the umbrella, and HA is maybe the stem of the umbrella. So it is probably the better description of the overall condition, so taking into account the amenorrhea as well as the GI distress, the anxiety, the immune effects, the bone effects, like that sort of it is a better container for all of that. Hypogonadotropic hypogonadism is, as far as I've been able to tell, it's basically just a synonym for hypothalamic amenorrhea.
Right.
So it's basically saying the gonadotropins are the FSH and LH. So hypo is low levels. So you have low levels of FSH and LH, and that means that your gonads, your ovaries, are also smaller than they should be and not working in the appropriate way. So it's just looking at it from a slightly different perspective of the gonadotropins and the ovaries as opposed to the hypothalamus and the missing period. So
Yeah, and for anybody who's confused, red S stands for relative energy deficiency in sport. This used to be termed the female athlete triad. That's what I was taught in college.
yeah,
So it has kind of branched out to include men, because they have found that this is not only a problem in women who
yeah,
lose their period, but men can also suffer from this. They just don't have that indicator.
yeah.
So this typically is seen with like having lots of stress fractures and getting sick all the time. And then you start having the underlying bone problems and insomnia and lots of irritability and anxiety and such. And
Yep.
then there's the overtraining syndrome, which just basically is the overexercising without losing your period, I guess.
Yeah, I'm not really familiar with overtraining syndrome. It probably has some relationship to underfueling and exercising. It seems to me like it is more sort of on the side of your body kind of um just getting so overused by the amount of exercise that you're doing that it doesn't have any time to repair and restore. And I mean, I think that that's most likely to happen in people who are sort of exercising every single day without fail. And I think it's really important to recognize that our bodies need rest. They need that time off to repair and to fix things. And if you're breaking down your muscles every day and you're never giving them a chance to basically rebuild, then at some point your body's just going to be like, I can't do this anymore. And so I think that that's more what the overtraining syndrome is. And
Mhm.
I haven't worked with a lot of people who have sort of been in that bucket. I've sort of seen it on a few blog posts or websites or whatever, and it does seem like the recovery from that can be quite challenging, because you
Mhm.
really do need a long time of resting in order to like really give your body a chance to restore and regenerate and repair all the things, all the damage that's been done over the years.
Yeah, and I think it's such a slippery slope because when you have HA, you're so stuck in this survival mode that you get so
Mhm.
you default to all of these behaviors and habits that you have acquired over the years. So you exercise out of habit, out of thinking that it's just something that, like you said, you're compelled to do. So you
Yeah.
don't stop
Or
for you
sometimes
realize
even
I am
more.
exhausted.
Yeah. Sometimes even more than habit. Sometimes it is obsession. And, I think it's reasonable to, work with a therapist if that's feasible for you, to sort of talk about like the underlying reason for why do I feel like I need to exercise every single day? Why am I choosing exercise over going out with my friends or my partner or my family? Um, I think that that's one of the places where another sign that your exercise is problematic. Like if you're choosing exercise over other opportunities that come up for you. I mean, obviously, like, yes, you should exercise sometimes. But if it's sort of like something unusual comes up and you're like, no, I can't go. I have to go to the gym. It's like, that's a red flag. Really think about why it is that you feel like you must go to the gym every single day. Like we were talking about before, your body actually needs rest. And, nothing is going to happen if you skip a day of going to the gym. Like literally nothing bad is going to happen. I
Mhm.
think that we just get so focused on this mindset of, looking at people who are totally sedentary and not doing any exercise at all and sort of taking that as like, oh my God, if I don't exercise for a day, that's what's going to happen to me. And it's like, no, it's just a completely different situation. I do think that, I do encourage people, like walking is great. Walking is really healthy for you. If you are somebody who's currently really sedentary, like, take some breaks during the day, get outside, walk around, go for a walk with a friend if you're not motivated to do it on your own. Um, I really do think that moving our bodies is good for us in many different aspects.
Yeah, I found that as soon as I was properly fueled, I no longer felt that compulsion to
Mm,
go exercise. So I think my brain is like calmed down and
yeah,
like all of the cortisol that was rushing through my system is kind of chilled out a little bit. And I
yeah.
actually wanted to touch on that. Can you explain cortisol's role in HA and the endorphins as well that come with exercise?
Yeah, so both of those actually send suppressive signals to the hypothalamus. And I think it makes sense. Like, I mean, if you sort of think of it from an evolutionary perspective, a lot of times when people have HA, they're like, my body's broken, it's not working. I'm like, that's actually not true. Your body is working exactly the way it's supposed to, because if you think back in sort of the species history, there were certainly times when fuel was limited and, people had to migrate to find more fuel. And that's a really bad time to get pregnant. So, all of the things, all of the different aspects of that send suppressive signals to our hypothalamus and therefore our reproductive system. Like now's not a good time. So when you're underfueled and when you're stressed, and, that stress can be either mental or physical. So mental stress can also impact your periods. Certainly, I think we all know stories of people who, there's the death of a loved one and they miss a period for a month. It tends not to be sort of a chronic amenorrhea unless you have sort of the underfueling component going along with it. So typically with sort of acute mental stress, that's more of a one-off type thing. And so it's not as much associated with underfueling, so it doesn't tend to lead to ongoing amenorrhea. But some of the mental stressors like calorie counting, step counting, weighing yourself every day, like all of that is chronic stress. And you add that onto the underfueling that tends to go along with that, and now you have, it's a concept called synergy. So it's actually worse for you when you have the stress and the underfueling than just one or the other. And so the cortisol that's generated from sort of mental emotional stress is no different from the cortisol that's generated from exercise stress. And so, it's just sort of that the cortisol molecules are suppressive to the hypothalamus. And, I think it makes a lot of sense why that is. So, I mean, that's why I sort of recommend when you're working on recovery to keep your heart rate at about 100 beats per minute or less, because that's not generating a lot of exercise-based cortisol. Um, I do think that cutting out some of those counting behaviors and everything can really help with, sort of day-to-day stress. I do tell people, like, I understand that the lives that we live are stressful, and you know it's really difficult to remove all stress from your life. But when you're fueling your body well and you're not doing sort of the purposeful stress-inducing movements,
Right.
then your body is much better able to cope with sort of the day-to-day life stress. And you know you can be you can be more sort of sanguine about those about those kinds of things that we're all subjected to.
Yeah, when it's not self-induced. I have to eat at this time of day. I can't eat at that, and I can't go out to eat. I can't
Yes,
like
yes,
so much,
absolutely,
too much.
absolutely, yeah.
So I want, before I let you go, I just want to get back to the yo-yo dieting. I have been researching the Minnesota starvation experiment, and it
Mhm.
is so fascinating. Like it's our only like one of a kind study,
Yeah.
able to see the actual starvation process and how our bodies adapt following such a long-term calorie deficit. And I like it was such a light bulb moment when they explained that like 40% of body fat is put back on that's like above and beyond what was on
Mhm.
the participant's body beforehand, like their typical baseline body
Yep.
fat. So, and then their set point was slightly shifted. Could you kind of talk about that a little bit?
It's
The
interesting that
yo-yo
you bring that
cycle.
up because that is what was sort of coming across. That was my light bulb moment for holy shit, what am I doing to my body?
Yeah,
Because
yeah.
I had significantly reduced my calories. I started waking up, at 5 o'clock in the morning, hungry, and I was like, no, no, I can't eat now. And then I read that, and I was like, oh my God, like I had no idea that this, that there were so many sort of negative effects all wrapped up in just just the underfueling and and then the exercise. And I mean, some of the, I think the men were sort of very significantly underfueling for their body's needs. And it was really interesting to me how obsessed they became about food. And I think that that's another thing that people find really improves when they start eating more regularly is like a lot of people find that they're just thinking about food all day long, and it's like that's your body's that's a hunger signal. That's your body telling you I need more freaking food. And so once you start actually feeling better, so many of those thoughts go away, and you can just sort of like eat when you feel like it, and it's not something that you're focused on 24/7. So that always really interesting to me. um
But
and
as
yeah,
far
I
as
mean,
the
I think
yo-yo,
what's that?
sorry to interrupt. As far as the like putting on excess body fat and then crash dieting again, and then
Yeah.
putting on excess body fat and then crash dieting again. Could you speak a little to that?
Yeah, I mean, I think that there is quite a bit of evidence that sort of each time you do that, that your set point gets a little bit higher and a little bit higher. So, I think really it's important when you're if you're even thinking about like losing weight, to not do it in a, to really just follow your body's hunger cues as much as you can. And, I think adding a little bit, adding some movement, I think is really helpful. That builds muscle, it increases metabolic rate. Um, I really struggle with the idea of ever telling people that they should lose weight. I have it's just it's sort of so antithetical to so much of the work that I've done in
Mhm.
body acceptance and, recognizing that, there's so much more to us than what our body looks like. What our body looks like is, it's just so much less important than what we actually do in this world and our relationships and all of that. And so, I sort of struggle with talking about the weight loss side of things at all. But I do think that, you know, another thing that I found really interesting about that study was the way that the men really sort of devoured food after they were no longer being restricted. Sort of. I mean, I think that some of them were eating like 8 to 10,000 calories a day.
11,000 for the
Yeah,
first week.
yeah. So I mean, and that's something else that I think a lot of people sort of in this HA recovery experience is this, sort of wanting all the food all the time. So sort of knowing that that's an expected thing that's going to happen, and it will settle down over time as your body feels more stable and safe. I think that's also really important. Um,
Mhm.
in terms of the longer term effects, I think that when they looked back at, when they went and looked at those same men years later, that their bodies had sort of settled back to where their stable set point was. And, that certainly is my experience, that after people recover, some people stay at, at the place where they recover. And, that's why I really encourage people to just kind of have that as their expectation. Like, this is the place that I'm going to be. And, let's work on accepting my body the way it is, accepting other people's bodies, really focusing on, focusing on things outside of appearance, like what can my body do for me? Like, my legs are, my legs are big, but I play ice hockey and I can carry my 80-pound son up and down the stairs with no problem. Like, yay, like that's fantastic. It doesn't matter that my legs are big. Like, who cares? So I think really, really focusing on that kind of thing, as opposed to, the numbers and getting stuck again on like, what is my body fat percentage? Like, when am I going to get back to my, set point? Because our set point's not always what our brain wants it to be, what society wants it to be. Like, I think really learning to listen to our body, and recognizing that sometimes, if you have sort of gone a little bit over the weight that your body is really happy at, it can take a while for it to come back to baseline, and not trying to pressure that process to happen faster than it naturally wants to, because then you're just kind of getting back into the same place again of underfueling and, all of the symptoms that come along with that.
Yeah, I think that's the major takeaway here, is to stop trying to artificially manipulate our bodies and micromanage everything about our diet and exercise to a point where we are causing ourselves this kind of detriment.
Yeah.
I
Yeah.
can't thank you enough for all of your knowledge and wisdom, and for
Oh,
coming on and
absolutely.
talking
My
to my
pleasure.
viewers today.
I did want to recommend a couple of books on
Yeah,
body image
please.
that I found really helpful. So there's More Than a Body by Lindsay and Lexi Kite. Um, there's Your Body Is Not an Apology by Sonia Renee Taylor, and You Have the Right to Remain Fat by Virgie Tovar. There's all really good resources to read and learn a little bit more, and kind of like have a bit of a mindset change in yourself, in terms of how you view yourself and how you view other people. So
Well,
I
that's what this did.
recommend these.
That's
Well,
exactly
that's
what we
fantastic.
No
You
period,
need
no
more,
what for
you need
anybody who
more than
hasn't done
that though. Yeah, and I do also want to invite people. I do have a podcast. It's called the All In Podcast. You can get to it by going to noperiod.info/all-in. And we've had lots of guests on body image, and doctors talking about the heart and bone effects of HA. And so that's another good place to learn more. So
Yeah, and Dr. Sykes has a wonderful community of very helpful and informative women who are all going through this process, that I am personally a part of that community. You also have wonderful resources on your blog, fact sheets and cheat sheets and all kinds of, there's even the first chapter of your book, which I thought was very truly generous. So
yeah,
thank you
thank
for
you.
everything you've done, because I know that you took a huge pivot in your life to like decide to
Yeah.
be so altruistic and help women with this problem, instead of doing your computational biology.
Mhm.
So we are all very appreciative of that.
Thank you so much.
Yes. Okay, great. And I'll leave all of your information in the show notes for people.
Perfect. Sounds good. Thank you so much for having me. It was really lovely talking with you, Carly.
It was so nice meeting you, Nicola.
All right. Have a great day.
I'll see you in the group.
Sounds good.
Bye.
Bye.